Welcome, everybody. My name is Susan Barber, and I'm the Community Education Manager at Mission Hospice and Home Care. And for those of you that are not familiar with us, and those of you that are familiar with chat, it would be wonderful if you would just put up in the chat where you're zooming in from today. But we are a small, non-affiliated, not-for-profit hospice that's located just south of San Francisco. We cover San Mateo County and northern Santa Clara County, which some of you may know of as Silicon Valley. We have a very robust community education program, and this is one of our offerings. We are finishing our author series this afternoon with Dr. Aronson, so thank you all for being with us. Just a couple of Zoom etiquette things for this afternoon. We're going to ask you to keep yourselves on mute until it's time. We'll have Q&A with Dr. Aronson when she is finished with her presentation. For people that would need to get up and move around the room or interact with other people that might be in your living space, we ask if you could use these small icons at the bottom of your screen. The stop video will just turn your video off. It will leave your name up there. And that's great if you have to get up and walk away or do any of those things. It's a little distracting sometimes if the speaker is speaking and people are doing all sorts of things in the background. I do want to let people know that we're going to record this in the hopes that we'll be able to use this as an educational opportunity. So I'll let the two people whose cameras are up here, in case you do not want to be your face recorded here, it's Francie Souza and Pat McNutt. And you're welcome to just stay there with your camera on or turn it off if that's not comfortable for you. I would ask if people later, if people want to share, at the bottom of your screen, you'll see something that says participant. And if you click on that, you'll see a little blue hand. And when it's time to share, it's easiest. There's often many of you here, and it's much easier to just see your blue hand if you have a question. Also, if you have a question during this, I will try my best to resolve it for you. You can hit the chat button, and just notice if you do that, a white box will come up. Your chat will be to everyone. Again, my name is Susan Barber. If you would like to chat with me specifically because you're having some kind of an issue or a question about what's happening. So with that, I want to welcome today our presenter. I'm so excited to have Dr. Louise Aronson with us. And I'm going to do an introduction of Dr. Aronson, and looking to see if she has turned her camera on. She'll be joining us in just 1 second. She's here in the room. So Louise Aronson is an MD and has an MFA as well. She's an author both of Elderhood, the book that we'll be discussing today, and possibly she'll be discussing some of her story collection, A History of the Present Illness. She's a geriatrician, an educator, and a professor of medicine at the University of California in San Francisco, or UCSF, for those of us that are locals, where she directs the UCSF Health and Health Humanities. Dr. Aronson is a graduate of Harvard Medical School and has an in the MFA program for writers at Warren Wilson College. She received the Gold Professorship in Humanism in Medicine, the California Home Care Physician of the Year Award, the American Geriatric Society Clinician Teacher of the Year Award, and her articles and stories have appeared in publications including the New York Times, New England Journal of Medicine, Lancet, Bellevue. She also has earned a McDonald Fellowship, Sonora Review Prize, 4 Pushcart nominations, and just recently, Elderhood was nominated as a finalist for the Pulitzer Prize. And I think this is the first time that we have had the Pulitzer Prize finalist with us. So welcome. For those of you who are interested in just seeing Dr. Aronson and not all the little tiny boxes, please take your cursor to the top of the screen where you can change the way your screen looks, and you can, it says speaker view, and you click there, you'll get a bunch of little boxes. If it says gallery view, click there, and you should be able to just see the speaker. So Louise, if you want to start, this would be just lovely. I'm going to just read this quote, which I love so much. I believe is the opening of the book, that we've created a society where we do everything possible to stay alive, yet we do not want to get old. We dread getting old. And I think that is a beautiful framing for the conversation that we'll have this afternoon.
Excellent. Well, it's so nice to be here. There are 3 pages of you, so I can only see some of you, but that actually helps because when you have to give a talk into an abyss, it's pretty hard to be enthusiastic. So I love seeing all the smiling faces. So I have my standard book talk, but since I last gave the standard book talk, the world has changed a lot, and I'm going to touch on the ways it's changed. I think the ways it's changed in terms of elderhood with COVID-19 actually prove everything I was talking about in the book, which I guess is useful for today's discussion, but perhaps understatement of the year, disappointing in the larger picture of how we deal with elderhood and how medicine deals with elderhood. One of the things about the book that people always ask is, well, so what is this word elderhood, and did you make it up? So I didn't make it up. I actually made up another word, which was called oldhood, that turned out to be both not popular at all and and grammatically a little bit inaccurate, since the point was to have an analogy to childhood and adulthood, because if you don't have a term for a long life stage, then you don't have policies, you don't have the attention, you don't have the job opportunities and everything else that the human beings in that life stage deserve. But my grammatic problem was that, if you have childhood, you have a child. And if you have adulthood, you have an adult. And if you have oldhood, you have an old. So although I was hoping to reform the word old, I'm using the word elder. And that actually serves to a benefit. So one of the early stories in the book, I tell a story about a colleague of mine at UC Berkeley who doesn't exercise with medical students, but has actually done this with many other people. And what he does is he gives them 1 minute to just respond to a word he's going to say. The first word he says is old, and they write for 1 minute. Then he says second word, and he says elder, and they write for another minute. And perhaps not surprisingly, some of the words he gets for old are wrinkled, bent over, slow-moving, bald, white hair, weak, fragile, feeble, frail, or sick. But the words he gets for elder are quite different. He gets respect, leader, experience, power, money, and knowledge. And I like to start with this because if you look up the two words, old and elder, used in reference to a human being, what you find is that they mean the exact same thing. So this shows how we bring prejudice to our terminology for old age and why we need to expand that. And we need to expand that because those prejudices against the words turn into prejudices against our lives as we become and are older. We saw this with COVID in the healthcare system and in the larger system, because as I'm sure everybody has seen, there were people going around saying, well, I don't have to wear a mask, or I don't have to worry about this because I'm not old. Or people saying, well, it's just killing old people anyway, as if every person who is old is about to die. The truth is that elderhood is one of our longest life stages. Childhood has a lot of changes in it, but it lasts, well, okay, you can make jokes about people's maturity. So for example, I have a nephew who's just turned 18, and I would trust him with anything. And I have another one who's 24, and I would trust him with nothing. So of course there's some variability in childhood, but we know we go through stages. We have a whole lexicon for that, right? You're a neonate, you're an infant, a toddler, a young kid, a tween, a teen, a young adult. And then maybe you're 18, like one of my nephews is. But for old age, we have all these terms and we sort of use them willy-nilly. Who's old, who's elderly, who's an elder, who's geriatric? What does it all mean? And as a result of that, people tend to lump old into a single monolith, and that's a problem. Does old pose true differences in life? We all know this. Line up a 60-year-old and a 90-year-old, and we can all tell that there's a difference. And you see this with COVID. It's really quite interesting. If you look at death rates from COVID in people under age 50, it's very low, maybe 0.2%. You get up to people in their 50s, it starts going up. People in their 60s, it goes up a little further. People in their 70s, it goes up significantly further. And people in their 80s, it goes up really high. 80 and over is a huge risk. So a couple things to note about that. That means there are differences as we age. But it also doesn't tell the whole story, because in each of those age groups, there is huge variability in how people have aged and what their risk is. And that kind of ties into our second national crisis of late, which is the crisis of health disparities and racial disparities. Because there is a difference in over 20 years of life expectancy between, for example, a Native American living in the Dakotas and an East Asian person living in Massachusetts. And Black and white people living side by side in the same communities with the same education and the same abilities to exercise also continue to have differences in life expectancy. So one of the problems with aging is that we lump all this together and we don't acknowledge that the differences within the age span or the variability within each category. So you've all probably heard about, oh, COVID is so lethal in people age 80 and older. When in the United States, the death rate in that age group is 15%. So that's really high. That's really scary. But the flip side of that is that 85% of people are not dying. And we don't hear that. Nor do we hear about something else that's really important, which is how sick are those 85%? And now we're beginning to learn that some of them are asymptomatic too. And some of them are symptomatic, and more of them need hospital stays. And for some of them, living through it is pretty arduous. So all those things are true of old age. But here's how the health system responded to this crisis. And I will use my institution as an example because actually we tend to do this better than most, and still our response was disappointing. So there was data from China and from Italy that old people were by far at highest risk, and that people who lived in congregate settings were at particular risk. So when does COVID hit the radar in the United States? Well, about the last week of February. Turns out it was around earlier, but we hear about it first in a nursing home, right? We hear about it with old people. In the first week of March, my medical center published guidelines for what to do if a child had COVID. The next week, it came out with guidelines for how to handle an adult with COVID. Now, we already knew that kids were far less likely to get COVID and to get sick from it. But that was the number one priority. And they set up ways of getting people into and out of the children's hospital. Then they did the adult hospital, basically pushed more when the public health department declared we had to. But there was nothing about elders. And so we lobbied and we lobbied and we lobbied. So by about mid-March, we were already hearing that older people were not only getting COVID in higher numbers, but presenting differently with it, which meant that especially in the highest risk group, those people over age 80, and those people who might have enough health issues and functional issues that they might have moved to assisted living or a nursing home, weren't always presenting with fever or body aches or a cough. Sometimes they were just more confused, and sometimes they were falling. Now, we knew this from geriatric specialists who were seeing them, because what we know that is not as well known more widely is that as people become older and as they become frailer at any point in old age, those are more common presenting symptoms of absolutely everything. And one of my colleagues joked as we were talking about this, she said, well, just because it happens with every other disease we know about doesn't mean it'll happen with COVID, so why acknowledge it now, right? Which was tragically apt. On a positive, UCSF was one of the first places in the nation to acknowledge confusion. There's been some pushback and falls and other things. And among the pushbacks were, well, that's not always going to be COVID. Okay, but we're having a pandemic, and if somebody is more confused or falling, one thing we know for sure is they need medical attention. So that seemed to us like a win-win. Importantly, when did the Centers for Disease Control add confusion to their list of presenting symptoms? Right? Their first list went up around early March. They added confusion in the third week of May. When did they add the syndrome, the inflammatory syndrome in children that has affected, obviously, just to be clear, a horrible disease in a child is a horrible thing. I'm not arguing like elders versus children. What I'm saying is we actually can take care of everyone simultaneously. We have different people who do all these different things. So at this point, we had many thousands of deaths, 20, 30 thousands, and those are just the ones we know about in older adults, and fewer than 100 in children. But they published about the different presentation in children really quickly, fairly soon after it showed up. But it took them many months to get to elders. This is part of why we need to start talking about elderhood, and we need to start owning the language for old age. Other civil rights movements have done that, taking back the words for being female, for being LGBTQ, for being Black. And yet what we see is that often even old people, and sometimes especially older people, don't want to have that language, but that makes everybody invisible. So let's just tie this into the bigger picture for a moment. Most of the people running this country are elders. The president is an elder. The Speaker of the House is an elder. The head of the Senate is an elder. Dr. Fauci is an elder. So being an elder, being old, being even among the oldest old, does not necessarily mean anything about your health and function. It means you have been alive for a long time. Just as being a tween means you've been alive longer than if you were a kid. We don't use this language when they're doing, apparently, there was actually, you should look it up, it's sort of amusing. There was an article in the Washington Post before Christmas about all the things that the candidates are doing to look younger. So apparently for Joe Biden, there's something that makes his skin glisten. So for those of you, like I could probably use some glistening myself anyway, Joe's your man. We need to kind of own that these things aren't mutually exclusive, because until we do, we become invisible, not just to health systems, but in larger ways. And the response to COVID has really shown this. There is also something called excess deaths. So this is when you look at, for example, April or May of every year, and you see how many deaths there are on average. So this year we had a bunch of excess deaths from COVID. But then actually there were more excess deaths over and above the COVID deaths. Why was that? Because most of us couldn't get tested, right? And particularly for older people, if they were presenting with atypical symptoms, they might never have been tested for COVID. And if they lived in a nursing home, if an old person who's frail gets sick, what do people say? They say, they were old and frail. And we have documentation of people who had classic COVID symptoms, but because they never got a test, what goes on their death certificate is one of their underlying conditions, like their heart disease. So it's going to turn out there was much more COVID, and that our ageist response to it covered up any number of tests and kept people from having opportunities for optimal treatment and care. And that's why we need to pay attention to all of this. So in the book, I talk about lots of things. I tried to make it entertaining, and I've got to say this was as much for me as for all of you. When I started this book, my editor said to me, well, you should write about old age. And this was just after Sid Mukherjee had written his fabulous Pulitzer Prize winning book called Emperor of All Maladies, which was about cancer. It's a big, thick book, not unlike Elderhood. And I was like, yeah, right. So I looked at successful doctor books and I realized, okay, they've got some memoir and they've got some science. And then the ones I liked best also drew from the larger society, showing how things come together. But I also noted that they all were sort of similar. They had 8 to 13 chapters of about 30 to 35 pages each. And so I set out to write that book. And I was about 3/4 of the way through, and my team at the publishing house was like, this is great, keep going. And I realized I was bored. I was bored because it just moved along. And I also felt like it didn't capture elderhood properly. If any of you have seen or read the book, you'll see it is chapters made up of smaller chapters, and I push literature against history, against science, against memoir, against patient stories. And I did that not just to make it more interesting. I know if I read certain sorts of books, I'll probably be more interested in the personal story than the fact part. And I have friends and relatives who are more interested in the fact part than the personal story. So one thing I thought was, well, everybody can kind of go quickly on the parts they like less and, end up back at a part that they like better pretty soon. So hopefully that worked. But I think there was also a larger intent, which was to show how old age is in every sector of our lives and society influences every other part. Medicine's response to old age is because of our society and culture's response to old age. And all these things really come together in ways that can be of a huge benefit to us and can do us grievous harm, as when health systems don't acknowledge the population that's being most affected. I was tweeting yesterday, so I got a push notification from the San Francisco Chronicle that the San Francisco Department of Public Health was going to set up an extra testing site for COVID so protesters could access it. And that's a great thing. They're taking risks. But many of my friends and colleagues have said that this is something for their, worth dying for, that they care enough about this justice that it's worth it to them. Okay, so then having testing sites makes good sense. I have been working on the COVID response for older people through the San Francisco Department of Public Health for the last month and a half, 2 months. We have been trying to get testing into congregate sites. So we finally now gotten through testing everybody in nursing homes, but we haven't tested people in residential care facilities unless they've had an outbreak. If you look at the numbers of deaths in San Francisco, you will see by far the most deaths are in skilled nursing. The second most are in assisted living facilities, and then less in other sites. And yet we've had more testing in other sites. So this is again an ageism thing where we see that there is a higher risk for disease in younger groups, but most of them fare quite well. Whereas there's a much higher risk of bad disease in older age groups. And that should matter. And in some ways, what these policies are saying is that one younger person having a bad outcome, because it's so rare in younger people, right? So 1 in 1,000 or something, is worth the 1.5 in 100 older people getting really, really sick. That has a different valuing of different lives. And when we value any other lives differently, we end up putting all of us at risk for being devalued, right? We've seen most categories of human being get devalued. If you actually look at the federal government's list of special populations, it includes almost all of us. So it's children and old people. It's anybody who's female. It's anybody who's LGBTQ. It's anybody who has any disabilities. It's anybody with black or brown skin. I mean, you go on, and what you end up with is that everybody is a special population except for an able-bodied Christian male between, I suppose, the ages of maybe 20 and 60. And I think when we begin to devalue most human lives, we're in trouble. So having talked about COVID, I also want to acknowledge the racial issues going on in our society and to talk about how they intersect and how all these things matter to all of us, because how we treat old lives determines in part how we treat Black lives and vice versa. So I'm going to read you a bit from the book here. It's sort of easier to read when you're not sitting in front of a small laptop propped on a bunch of books, but I'll do my best and bear with me. So you'll see how I bring in some literary and historical stuff, but then I'm going to move to a patient case and some memoir. This is from a subsection called bias. In The White Album, the author Joan Didion quotes a transcript from the Alameda County grand jury in which a nurse describes the day Black Panther founder Huey P. Newton shows up at the Kaiser emergency room with a bullet in his stomach from an encounter that left one police officer dead and another wounded. Newton became a political martyr as a result of this incident and received a subsequently reversed prison sentence of 2 to 15 years for voluntary manslaughter. During the quoted exchange, Newton asks for a doctor, and the nurse, who describes Newton as, quote, this Negro fellow, imagine similarly like this little old lady, repeatedly asks whether he's a Kaiser member. She insists that he sign the admissions sheet while he yells that he's bleeding and needs medical attention. The year was 1967. Okay, so now I'm not going to read the rest of that. I'm going to skip forward. 42 years and 14.1 miles from the hospital where Huey P. Newton showed up with his gunshot wound, a patient of mine arrived at the emergency department of our university hospital. Mabel was confused with slurred speech and a fluctuating level of consciousness, meaning she was alert sometimes and sleepy or hard to interact with at others. Tests were done to determine what was going on, including a toxicology or tox screen, that's the lingo we use in medicine, which tests for certain legal and illegal drugs, which is a fairly routine test when patients have what clinicians call, quote unquote, altered mental status. So far, so good, right? Except that Mabel was 94 years old and had been bedbound and fed through a tube for nearly 5 years after a devastating stroke. While she was too confused to be able to relay the details of her condition, it could have been diagnosed from the doorway of her emergency department cubicle. The ancient face, the unnatural kink of her neck and left arm, the feeding tube puckering her gown where it jutted up and dangled from her abdomen. Alternatively, the doctors and nurses taking care of her might have glanced at her chart that prominently listed her age and underlying conditions, or they could have asked a few basic questions of her concerned daughter, who stood at the bedside stroking her mother's forehead and murmuring soothing words, or her 2 sons waiting in the waiting room. Any of those approaches, all of which are such routine parts of the initial patient evaluation that they have standard labels: general appearance, chart biopsy, and past medical history, respectively. Any of those labels would have made clear, or any of those approaches would have made clear that by far the most likely cause of Mabel's altered mental status was delirium. So delirium happens, it can happen to anyone if they're gravely ill, but it happens much more commonly to any of us who become sick as we grow old. So that is the confusion I was talking about with COVID. It's more likely in people who have an underlying cognitive disorder, one of the dementias, but it can happen in any older person, particularly as they move through the decades of old age. That was not in the book, I just said that. Now back to the reading. Unless an acutely confused older person is hit by a car or found with a heroin needle in a vein, they should be considered delirious until proven otherwise. So this is different than for younger people. Yet the doctors caring for bedbound 94-year-old Mabel sent a toxicology screen. It may well be that they did this out of habit or because they were following an illogical, expensive, age-blind protocol. But those aren't the only possible explanations. I know because I had a control patient. So controls are people without the condition when we do medical science. So I had a control patient, also old and quite debilitated, who was seen in the same emergency department in the same month as Mabel. For the better part of the last decade of his life, from his mid-70s to his mid-80s, my father became delirious every time he entered the hospital. He had delirium from a heart attack, a knee replacement, cardiac bypass surgery, pneumonia, an allergic reaction, a bladder infection, another orthopedic surgery, and 2 falls. On exactly 0 of these occasions was a toxicology screen sent by the emergency department staff tending him. Since drug abuse is less common in females than in males, and less likely among the very old and homebound than along the mobile and not homebound like my father, it would have made far more sense to send a tox screen on my father, if you were practicing evidence-based medicine, than it made sense to send one on Mabel. But that's not what happened, even though their presentations were similar. Medically, both were old and frail with long lists of diagnoses. Socially, both were accompanied by supportive, educated families and had me as their advocate. Really, aside from her negative risk factors of greater age and disability, the biggest difference between Mabel and my father was skin color. My father was white, while Mabel was African American. It seemed clear the resident treating Mabel couldn't imagine her beautifully appointed single family home filled with generations of family photographs and religious artifacts. Not that any of that should have been relevant to the care she received or deserved. So there's another paragraph I'm going to skip, and then I'm just going to pull all this together, hopefully. The handling of Mabel and my father's delirium that month illustrates the importance of intersectionality. Society's multiply interacting and historically ever-evolving systems of privilege and oppression, inclusion and exclusion. Intersectionality shows that it's never accurate to consider a person solely on the basis of just one of their defining categories, such as your age. Mabel wasn't just Black or female or old, she was all three and also disabled, heterosexual, educated, deeply Christian, well-groomed, and so much more. All those factors are always relevant in human experience, playing out not only across individual lifetimes, but through generations in ways both good and bad, depending on who you are and where you live. So that brings me to another comment about our two sort of public health crises, which is they are related. People of all, older people who are dying are of all races, but they are probably disproportionately Black and brown. But here's something what we're not looking at. Many states aren't gathering data on race. Most of the sites you look at aren't showing us both race and age. They're showing one or the other. So when we hear about this pandemic, we hear that old people are affected. And we hear that Black and brown people, particularly African Americans, are affected, although in San Francisco it's been more Latinos. And sometimes those are for different reasons, but it turns out they're actually kind of related, and they're related in a bunch of ways. Some of the lower quality nursing homes have had more deaths, although data out yesterday showed that it's happening at 5-star places as well as at 2-star places. The linked factor here is the Black and brown essential workers who are going back and forth. They are not paid enough, so they're actually paid what ends up being minimum wage or lower, which is why many work in more than one facility. They take public transit, which means it's hard to keep away from other people and their germs. They are more likely to live in congregate housing, which means that if somebody else, another type of essential worker in their home has it, they will get it. It also means that if they are working in a nursing home with COVID, they will bring it back and bring it to the other people who are living in their cramped quarters, and they will bring it to someone else. This is how this epidemic has affected these two populations. And then, of course, there are the people who are in both categories, because a lot of the caregivers we know in San Francisco are older themselves. They're in their 60s or 70s and caring for other people. So this is another ageist thing where we talk about caregivers and we talk about care recipients. I think most people know that most of us are both those things throughout our lives, and that many of the people who are providing much of the care to older adults are their not so young spouses, partners, and adult children. When I was thinking of what kind of doctor I wanted to be in medical school, I started out thinking I would absolutely be a pediatrician. Everything I had ever done was with children. Now, part of that was when you're young, you get offered a lot of opportunities to work with children, and you also see children in ways you might not see older people. But at my school, there were classes about children in psychology and sociology, children's literature. There were classes everywhere. I don't recall any classes about old age. I know there are some now, and maybe I missed it, but if there had been a lot, my interests were such that I might have seen it. So I thought I'd be a pediatrician. Then I found out the doctor's role in pediatrics has a lot to do with torturing children, and they're never happy to see you. And so that was off the table for me. And what I found was with older adults, the potential was huge because we actually had decent medical science, but nobody was using it. And nobody was thinking about old people the way we might. And also, if you're a person who likes stories, then the older the patient, the more stories the person has, the more life they have, the more pleasure in the interaction, and the more you can get to know the human being. Which is something that makes medical care so pleasing, I think, as a human being, and which is part of why we're now having a burnout epidemic, which I also talk about in the book, because we're now expected to spend more time tending the computer than tending our patients. But I think we need to realize that the people protesting in the streets aren't just protesting something abstract or something that has to do with youth. It's something that relates to all of us in various ways. So the same way Mabel was discounted, she was discounted for being old, and a talk screen was sent because she was Black. And there are ways this play out in all sorts of ways, ordering tests that don't make any sense. In the book, I talk about this a lot, where what medical care tends to do today, and we saw this again with the COVID response, was really focus on the organ system or the disease. If you look at protocols for treating COVID, most of them have to do with the disease alone. And they don't assess a person's chance of recovering from the disease. So they might, when we were hearing about rationing ventilators, and there was actually an incredibly poignant article in the New England Journal about this by one of my colleagues in Boston. But, Italian doctors talked about having an 80-year-old who was super healthy and a 60-year-old who was very sick, and being pretty sure the 80-year-old would live and the 60-year-old would die, but having to give the care to the 60-year-old, not the 80-year-old, just based on age. So age matters, right? We see with COVID that with each subsequent decade, starting at age 50, your risk for death goes up. Age matters. But age is not the whole story. Age is part of the story, and it's part of the story for a variety of reasons. One is the older we get, the more likely we are to have what's called comorbidities, so the underlying conditions that increase risk, such as heart disease, such as lung disease. Those make it harder for you to survive or to not get very sick from COVID. So that's one way old age matters. A second way is that the immune system changes as we get older. It changes in a variety of ways that sound familiar. There's some complex science, but it's actually sort of similar. There are things that slow down. So for instance, the immune response sort of has this 1-2 punch. One is the white cells come in and they release these inflammatory factors that help us respond. And that works reasonably well as we get older, although some people have fewer of those cells. Now, that initial response is important. But if it continues, you end up in this hugely inflammatory state. And so you actually want it early on, and then you want the second punch to come in, which is the T cells, and they start taking care of the problem. But as we get older, the white cells actually present the antibodies or present the disease to the T cells, and they present more slowly. Think of if you're older or if you've seen an older person, you might still be able to run to the corner. But I know even in my 50s, me running to the corner looks very different than it did even 10 years ago, right? And certainly it looks different than it did 30 years ago. So that happens more slowly, which means the T cells get the message more slowly. There's also fewer T cells, right? We know some things, there's less of different things, and they do their job less efficiently. So as a result, we end up more of that inflammation. And when you're hearing of people with with, sort of ARDS is the term for it. It's sort of a sepsis-related condition. It's a very big inflammatory state. That is how many people are dying. So that's one of the ways that the changes in the immune system with age can really impact how people can do if they're very sick from COVID. So the first one was having other conditions. The second one is the changes in our immune systems as we get older. The third one is if you're very sick, you may well rally, but each of the organ systems works a little less well than it used to. So if you think about, we usually call it physiologic reserve. So that's how much extra you have. It's kind of like if you're, say you make rice for dinner every night, and you take your scoop of rice and you're cooking it, and then you get distracted and you burn it. So not good for that rice. You might want to make more rice. Well, if you have a big thing of rice, you can afford to burn it and mess up the rice a few times. But if you don't have so much rice left, then you burn it and you just don't have maybe enough rice left to make dinner for everyone. So I'm not sure that was my best analogy ever, and I apologize, but it basically means like if you need more of something, you don't have as much to call on. So you may be sick mostly in your lungs, but your lungs are, and this is a fourth way, your lungs are less elastic. They have less reserve. And sometimes we see kidney dysfunction and heart dysfunction with severe COVID. And all the reserve goes down, which means it's harder to recover. And that even if you do get better from COVID, it's going to take you longer to fully recover. So the disease looks different. Now, how does that matter? Like, how does having elderhood and recognizing those differences, the fact that we've got pediatrics and then internal medicine, why do we also need geriatrics? Well, part of the problem with our response to COVID, which is just like our response to all other diseases, is that we basically, we go after it in an 80-year-old just as we would go after it in a 40-year-old. Even though I've just described the 4 ways in which the 80-year-old's body is different. And so I think we need elderhood as a society so that we have experts across all sectors, just as I think we need much more geriatrics. And that's not just because I'm a geriatrician, right? Yes, I'm a geriatrician, but partly I'm a geriatrician because when I was a general internist, I realized that I was hurting my older patients whenever I treated them as if they were younger. And once I learned about older bodies, I could do much more good and less harm. Now, this happens in society too. We don't just need geriatrics. We need elderhood and we need substages. Why? Well, here's one example. Older adults are the fastest growing segment of the American workforce. And there are a couple reasons for this. It's mostly people in their 70s, although a lot more people in their 80s and tons of people in their 60s too. But the biggest uptick is people in their 70s. Now, some of this is because people need money, right? When the retirement age was set at 65, the average age of death was 67. So you got retirement benefits and it lasted the few years that you lasted, maybe a decade, and that was enough. But now if you retire at 65, heck, you may live 20, 30, 40 more years. You may not have saved enough to live that many decades. So that's why some people do it. But there's a second really important reason, which is that work, broadly defined, brings each day shape. It brings social opportunities, intellectual opportunities. It brings meaning and purpose. And there is no age at which we as human animals don't need meaning and purpose. I mean, I think there's your basic things. There's your shelter, your food, your all of those things. And then after that, we get to kind of existential things that make you wake up in the morning and think, I know why I'm here, and I know what my day has in store for me, and I know what I'd like to accomplish. So people are really finding that's necessary. But they may not want to work a 40 or, in my case, a 60 or 80-hour workday. They may not be able to do that, or the costs of doing that will go up. In my residency, I was in my late 20s, and this was before all the work hours reform. So I routinely worked 100 hours a week, And sometimes I worked 110, and yes, I was tired, but I'd go home and I'd sleep and I'd be, essentially okay. Because when you're 28, you can do that kind of ridiculousness. Some nearly 30 years later, I think I'd be walking into the walls. I'd crash the car. I wouldn't remember what to drink. That's crazy. So in another 30 years, I'm certainly not going to be doing that. Now, can some people do it? Are some people more resilient than I am? Without question. Do I have colleagues, some of whom can do it? Yes. But I think when we think about work in older age, another reason to have an elderhood is to think about, what does that look like? If it's a different life stage, then maybe work looks different too. Maybe you're not going to be using a sledgehammer all day if that's what you did. You're going to do something different. Maybe your work week is going to be 20 hours, and that still gives you enough time for the rest and recuperation and for the other stuff that you've earned by working so hard for so many decades, for more rest, for more exercise, for more social activities. Because we know as people get older, they're also better at prioritizing what really matters to them. There is something called the U-shaped curve of happiness, which comes as a surprise to many people. And it shows that people are quite happy in youth. And then as they enter adulthood, their happiness and life satisfaction start going down and their anxiety starts going up. And really the nadir is in the 40s and 50s. And then in the later 50s, people start getting more happier again and less anxious. And it just goes up through the 80s. Through the 60s, 70s, 80s, and even in the 90s on average, in these wide studies that are across most of the planet, not the poorest of poor countries, but most others, people are happier. Now, is there probably some selection bias? Yes. Do I think they were asking people who were gravely ill? Were those people answering survey questions? No. If people are really in pain or miserable or in a skilled nursing facility, they're probably not surveyed. So there's some bias, but the numbers are so overwhelming that even with a little bias in the extremes, chances are that there is some happiness. And when we look into that, what we find is that people realize, that the clock is ticking. And we talk about, Susan mentioned at the beginning, this thing about, nobody wants to die, but nobody wants to grow old either. That is a lose-lose proposition. Like, you've got a choice, and I'm pretty sure growing old is the better option in most cases. So thinking about how to do that, and also considering that we make it harder than we need to make it in so many ways. If we had work opportunities that would allow people to thrive, if we had homes, in our homes, we tend to have like cute, colorful things for kids, right? To adapt a home to a kid. And for adults, we have all these sort of sexy, stylish things. I mean, the numbers of things that you can get to, like even the knobs on your cabinets. I mean, there's tens of thousands of them, literally. But then if you need to adjust your home so that you can age in place, so maybe, you feel safer or it's easier to get in and out of your tub or your shower. Not that you even necessarily need it, but you might, or if you're having an off day, as we all do. Things like that. What do you get? You get ugliness. You get such ugliness. You get things that make your home feel like an institution that you don't want to look at, that you don't want other people to see, that you feel ashamed of needing. It does not need to be that way. That is a failure of creativity, and that is straight up ageism. Those things could be as cute and sexy and stylish as everything else. What's more, those things would help any number of people. They would help a hugely pregnant woman. They would help someone with a sprained wrist or a broken leg. They would help people who weren't able-bodied for whatever reason. They would help little kids. So if we didn't live in an ageist society, we would have homes in which it was easy and aesthetically pleasing to age in place. And if we didn't have an ageist society, we would understand that when we set up COVID treatments, if we know that the immune systems of older people are different, then we should approach treatment differently. And we also have to address that ticking clock, because what you're willing to go through for another year of life is different for most people if they're age 40 than if they're age 95. And it's different if they already have an advanced condition of one kind versus if they were completely healthy to begin with. So when we deny age and we deny the greater proximity of death, we lose an opportunity to talk to the person about what matters most to them. Um, and that means we can't actually make treatment that's perfect for that individual. What we're doing is making treatment that's one size fits all, when we know from every segment of life that one size does not fit all. So that is a lot of talking from me. I'm going to read a small excerpt from the end of the book, and then I would love to hear your questions and answer any I might. So this is sort of my call to arms towards the end of the book. And I will say for some of you who may be dyeing your hair that I quite happily dyed my hair for several decades. But then I wrote this book called Elderhood, and I decided I could not be a hypocrite. And so I grew out my gray hair. Which has mostly been an absolute pleasure in feeling like the authentic me. Am I sometimes mistaken for being older than I am? It does happen. You know, do I sometimes sit on panels where I might be in the middle of age range and people think I'm the oldest? Yes. But I can't very well say there's nothing wrong with being old and have trouble with that. I am, however, human, so there are moments where I have trouble with that. So I just want to acknowledge that this is hard for all of us, and that it also has its tremendous pleasures. For 1 month in 2018, I conducted a thought experiment. Everywhere I went, I imagined the people I saw without hair dye or implants or comb-overs. The more I looked, the more I found, after all, men's first gray hairs generally appear at 30, and women get their first on average by 35. I saw people from all ethnic groups. I saw people who looked rich and people who looked poor, people who were adults, middle-aged, senior, old, elderly, and aged. Everywhere I looked, including in the mirror, I saw people pretending to be something other than what they were. How can it be we have created a society where a majority of adults and elders feel ashamed of their basic identity? And if we are pretending to be something we are not, how can we be surprised or disappointed when others disparage what we are? Imagine if everyone who is middle-aged or old looked middle-aged or old. Imagine if when we looked at our bus drivers, nurses, world leaders, teachers, rock stars, investment bankers, caregivers, cops, doctors, tech executives, grocery clerks, real estate brokers, lawyers, manicurists, and favorite actors, we saw what they really looked like, who they really are. Imagine gray, white, and absent hair signaling what it means biologically, the completion of youth and the ascent of maturity. Imagine if all those gray, white, and absent-haired people did all the things they already do. Imagine we liked, loved, respected, admired, and were inspired by them, by ourselves, as we already are, and when they or we got older still and needed some help, we offered a world and a worldview that said, we still see you and we still like, love, respect, admire, and are inspired by you, both for who you were and for who you are, a person completing the full natural arc of a human life. Imagine old seeming to all of us, whatever our age, more good, less other, and more us. So I guess I want to get us away from considering old as bad and young as good. Because the fact is, there are horrible things about being young. I don't know about you, but I don't think I would be 16 or 17 again for, $50 million. Well, okay, 50 million's a lot, but still, think about it. Okay, so I will stop talking. Thank you all for your attention under these sort of arduous circumstances, and I'm happy to take questions.
Louise, thank you so much. What a beautiful talk. That last part that you read, this is, like you said, I think I got my first gray hair at 35, and then I just don't get any more. I can't, there's no explanation for this. My siblings are all younger than me. They've all gone gray, and I'm 60.
So that's your real hair?
Oh yeah, I've never dyed my hair in my entire life. There's some gray coming in, but I'm like, I'm 62 and a half years old and I want to look 62. It's been a long life and I want to look like it. So I think this one, if there's anything at all that has been beneficial about COVID, which I think is only this little thing, is just because I'm here all the time, I just started sometimes at late night or just looking at the television, which I don't normally do. And you see all these people who are like beautified up like tremendously, but now they're sitting at home looking just like everybody else does. And they're disheveled and they're just, I feel like if
They're
there's
human.
anything they have done, yes, they're just like everybody else, just our common humanity. And I feel like this sort of COVID sort of ripped the veil off of this sort of pretense. And I wonder when this is resolved in any way, or whenever it is, when people go back to sort of normal life, people that get their hair dyed, like they're just going gray. Like this just, you can't go to get your hair done. And I just feel like, thank God, like that we could just look the way we are meant to look at the age that we are. So I love that last part. I also am just wondering if you could talk a little bit about this sort of um, dynamic of more and more and more people are aging and staying alive for longer, and there's fewer and fewer and fewer geriatricians available to treat those folks. And um, this is a concern of course, if I'm aging, I want to have a geriatrician like yourself. But it seems like there's fewer and fewer people looking at that specialty. And could you just talk about that a little bit? And what does that mean for people as they age and look for appropriate care?
Right. Well, it's a huge challenge. I mean, not a day goes by that we don't get some request. Does anybody know a geriatrician in X and such place? And we have some at UCSF, but
Yes.
there aren't many who take new patients because everybody's practice is full and because we have people who also do research. But this is a national problem. There is hope in a couple of ways. One is this current young generation is interested in aging in a way their near predecessors were not. We are seeing more and more students interested in aging. Our special interest group is getting bigger. Now, it does take us about 10 years. Like you put the medical student in the oven and he or she does not come out a geriatrician for about a decade. So this does not solve our immediate problem. And it's not like they're great hordes flocking to it. I have argued with some support from others that part of the problem has been our approach. We've actually had the same approach to geriatrics since the 70s. And my feeling is that if something you're doing has not worked for a half century, you need to change what you're doing. Admittedly, we are all existing in an ageist culture. But when the term geriatrics was coined in the early part of the last century, it was coined very explicitly to be an analog for pediatrics. And the notion was you would have specialists for childhood, specialists for adulthood, and specialists for elderhood because of the significant biopsychosocial differences in those three age groups. But because of ageism, probably, and because in those days there weren't so many old people, not so many people went into geriatrics. So the geriatrics community response to that was to say, well, there are very few of us, so we're going to focus on the people who are the most old. So the oldest old, the frailest old, the people who are most different from a healthy middle-aged person, let's say. And there's some good reason for that, right? If you have special skills, why not use them on the people who need those special skills most? There's a reason, there's a logic to that. At the same time, it becomes self-perpetuating. So people will say, I'm not so interested in geriatrics because it's so narrow. Because what they see it as a specialty not for old age, but a specialty for frailty. Now, do frail people deserve really good medical care? Without question. Do I love caring for them? Absolutely. All of us who are geriatricians do. But we're also, by not engaging people who are young and healthier, whether they're 60 or 87, we are pushing people more quickly towards the frailty, right? We're not applying everything we know about aging to keep people healthier longer. So about a year and a half ago, I started a new clinic at UCSF to try and focus on this, to really think about elderhood and can we help provide care for people to forestall the frailty. Not meaning that I'm not also going to care for you when you're frail, but most people, rather than becoming frail and getting optimal care, would rather delay that. And there's no reason we can't do both. I also believe that if geriatrics becomes what it was intended to be, a specialty that deals with people from their 60s through their hundreds, just as pediatrics deals with neonates through adolescence. There are subspecialist pediatricians who only do neonates or only do teens, and that's great. We would have that too. But think of how much more interesting we would be as a field, as a specialty, to young people, if they could approach it any number of ways. There are all sorts of health tech. The gerobioscience is a huge and growing field. There are so many different ways it would be of interest to our trainees if it were bigger and more varied. And then there would be more of us, and we could take care of older people at all ages. So this is my vision. We now have a special interest group at American Geriatrics, and we're trying to get more interest in this. If any of you have any interest in supporting this effort, please do let me know. We're also working on a study in San Francisco to try and help people age in place and optimize that. So there are opportunities for contributions for anyone who's interested, but it is, I think the potential here is huge, and the boomers are not going to put up with, I think the silent generation was called silent, and what we need now is noise. Like, I'm old, I have rights, and I don't need special rights, but I don't need to be treated like a second-class citizen.
Thank you so much. There's a couple of questions that people have put up in the chat, and Michaela is asking, they're related to COVID. One is about how is the treatment for elderly folks different in COVID? And the other question from Marilyn Meyer is, how can seniors who, because of COVID, have lost the shape and purpose of their life and because of other conditions don't see returning to life as they've known it prior to COVID? Which I think is something that lots of people are dealing with right now.
Yes. So the first one first, it's not being treated differently. One of the things that is happening at some places, though perhaps not as much as it should, is COVID-specific advanced care planning. So going to sites like Prepare for Your Care and really thinking about, if you're over age 80 and you have, or maybe even in your 70s, and you have other conditions, and maybe if you're in that age range and you're pretty healthy, but you become really critically ill, maybe you don't want a ventilator. So what's happening is not that everybody dies. For older people, some are asymptomatic. Some are symptomatic and do fine at home. Some are symptomatic and need to go to the hospital and get supportive care, oxygen, and the other things we're doing. But if you're really old and sick, and you're critically ill and you need a ventilator, the chances of coming off that ventilator are really, really, really bad. And the quality of life, if you do come off, is also looking to be very bad. We don't have a lot of data on this because most people don't come off after weeks on a ventilator, and many people remain on a ventilator after a long time. So what is happening is a lot of people are saying, look, if I have some other condition, I absolutely want full-on treatment. But if I have COVID and I need a ventilator, then please just transfer me, and I would rather have comfort care. But that doesn't mean you don't treat it up to that point, right? But that's one decision tree. And I'm going to just say, like, a fourth time, it doesn't mean you don't go to the hospital. It doesn't mean you don't get care, because what most people need is supportive care, and then maybe a little rehab. But if it's really at the extreme, maybe you want to make a different decision. I actually have a good friend who will be 77 this summer, who walks several miles every day. And that's her advance directive for COVID. Not that she wouldn't get treated, but if she requires a ventilator, she says, I've had a great life and I don't need to have a terrible life. And luckily it hasn't happened yet. So, in terms of other treatments, there are not differences. What you should know, and this will probably be hitting the media soon, is that a colleague of mine is looking into trials, so drug trials and vaccine trials. And there's still a fair number that are excluding older adults, even though those are the people most likely to die. It can be more complicated for all the reasons I said. Older and younger people are different, but my pushback against that is that if we had a disease that affected some adults but mostly affected kids, let's say we had a disease that affected kids and adults, but that the kids were more likely to die, we would have kids-specific trials. So instead, we have a disease that affects adults and elders, much more so than kids, but the very bad events are in elders. And there are no trials that are elder-specific, and there are trials that exclude them. So this is where speaking up and owning your old age, right? Have we heard Nancy Pelosi or Mitch McConnell or either of the candidates talk about what is essentially their people? not getting the attention they deserve. We have not, because they're pretending they are not what they are. If we pretend we're not what we are, then we don't look like a huge group of people who need and deserve equal care. So that's the treatment angle. So the next thing is a really good question. And actually, I have an article about this coming out in the Times on Monday. So increasingly, and from the beginning, in fact, we geriatricians have been concerned about how our response to the pandemic, to one public health crisis may be causing a second public health crisis, especially for people who live in smaller rooms, but really for everyone. There is the stress of never feeling, if you live alone, never having human touch over the space of 4 months. There is risk from not having purpose in your day, from not exercising as much as you might. And I think for older adults, it's all the more so because up until a few weeks ago, this is getting mitigated a bit because we've been pushing back against it, but telling people like, oh, it may be like this for a couple of years. Well, think of that shortened horizon we were just talking about. A couple of years under lockdown, if you don't know how many more years you're going to live, is a huge percentage of the whole. And even if you're going to live 20 years versus 80 years, 2 years is a much more significant percentage. And there's not seeing new grandchildren, and there's just all kinds of things, or being worried about returning to work. Our clinic reopened for certain services last week, and on the call we had the week before, I was looking, it was a setup much like this, and I have certain colleagues that do the sort of hands-on medicine that was in the first wave of restarting. I, as a geriatrician, in the final wave, so as to not bring the older adults in so soon. But the colleagues who are doing that work are in their 70s. And so I was getting these private messages from them saying, what do you think? Should I do it? Should I not do it? On the other hand, I also had an email from a surgeon colleague of mine who had initially been behaving, as he said, quote unquote. And then he realized that, he was going to take every precaution, and that going to work and operating on people really made his life. It gave him that sort of purpose and sense of accomplishment, and he was going to be extra cautious, but he knew how he wanted to live, and so he went back to work as a surgeon. What can you do? We've actually been working hard at the Department of Public Health at what sorts of activities people can do to open things up. There are the sort of meeting outside. I mean, we're sort of lucky that it's summer. It's relatively nice in most places, although some Arctic winds today in San Francisco, but that's San Francisco for you.
You're in Alameda too, it's freezing.
Oh yeah, I was gonna say Arctic by California standards, naturally. Minnesotans wouldn't be impressed. So, can you meet outside and sit at opposite ends of a picnic table? Can you wear masks and go for walks? All these things are important. San Francisco, think about how your local public health department is dealing with it. So as things began opening, we saw in San Francisco that tons of people weren't wearing masks. And so the mayor made it an edict, because otherwise we had an ageist society, because young people were saying, what do I care? Which is so disturbing, because it's not even about them. Like, you wear a mask to protect the other people around you. And it was sort of like, I don't care about my fellow humans, which is deeply disturbing. One assumes that most people have parents and grandparents and teachers and bosses of whom they're fond, but perhaps there are really legions of people who've never had that experience. I don't know. I can't really explain it. But there were tons of people, mostly younger white people, going out without masks. And so we made a public health edict that you had to wear a mask, and that's how you make it safer for people of all ages to go out. Because if everybody's wearing their masks, then you can go out for a walk, and you can go out and meet people at the park, and you can do things like that. Also consider, if you can do this kind of online thing, whether you can teach online, whether you can take classes online, whether you can do any of these other things. I think we're going to see more opening up. But there's been somewhat of a digital revolution. There were always there's something called the digital divide, which is partly due to income. Can you afford a device? Can you afford internet connection? And partly had to do with age, right? Because even I am not a digital native. There are things that a a 5-year-old can do, apparently that a 10-year-old can't do. So the rest of us are doomed. Like, but it doesn't mean we can't do anything or that we can't. And this is a key thing about old age, is like adapting and realizing like, okay, it's probably going to take me like 4 minutes longer to do this than it would take my nephew, but I'm still going to do it, because if I do it, then I get to have this lovely experience. And that's okay. So using digital techniques, volunteering for things, whether it's with elders or with kids. I mean, kids are home, parents are going crazy. I don't know about you, but like all the parents of children of any age that I know are really having a hard time. So can you help? Can you be babysitting over the internet? Can you be doing some tutoring? I think it is this adaptation thing. And we know from old age that people who thrive as they get older adapt, which means like, I like doing X and such activity. I can no longer do it. What could I do that would give me similar pleasure? And actually a guy who was interviewing me, for an East Coast paper a couple weeks ago, told me an example of a man in his neighborhood. And this guy was always running long distances. So for years, they'd seen this guy running. And then when he reached, I think, 80 or in his late 70s or 80, it just wasn't safe, or he was having trouble. It was painful. So then he started riding his bike. This is obviously an exceptional guy in any number of ways. So, he starts riding his bike, going on these huge bike rides. And then most recently, he's now, I think the guy said he was 93 or 94. They see him walking through the neighborhood, and he leaves and you don't see him coming back for a good couple of hours. So he changed. As he moved through his elderhood, he needed to change the activity, but he remained a man who needed to be outside moving his body. And he figured out a new way to do that. And so I think, I hate to give sort of what we call exceptional elder examples, because even I am not living up to that man's example. But I think that the greater point is his adaptability. And I do tell stories in the book, including one about 2 patients I had in their 80s who had strokes basically the same week. And one of them pretty much gave up on life, didn't want to go out and be seen with her stroke, and just stayed home and was really depressed and isolated. And I had just seen her and was thinking like, oh, what am I going to do? Do I start an antidepressant? How am I going to support her? We need to get her moving, and realize there's so much more that she can still do. And I was supposed to see the other one, and I got a cancellation. This is when I was doing house calls on them. And I thought, oh no, her too. And I called, and she said, oh dear, I'm so sorry. It's just that, today is my movie day, and I haven't gone out, to the movies since this happened, and we figure we've got the wheelchair, and so we just thought we had to leave early. And if you can just see me next Tuesday instead, I absolutely want to have our appointment. And they had basically the same stroke, and one of them was still living her life. She was letting her friend help her. She was going out, and what she actually told me the next Tuesday was that she was absolutely shocked by how nice everybody was at the theater, making way. And she said, I talk to more people. Like usually we go in, we sit down, nobody talks to us. Today, everybody talked to me. So some of it is about how you grab that difference and own it as like, I'm still me, I'm still okay, and I'm still worth talking to.
I love that story so much. When I was 28,
so much.
Oh my gosh. When I was 28, a friend of mine asked me to run the San Francisco Marathon with her, and I declined because I was smoking a pack of cigarettes a day, and I just didn't think those 2 things went together. She said, you really have to, because my friend Ada is going to leave me as soon as the gun goes off. I said, she's 70 years old. I don't think that's possible. And she said, come and out and meet her. So I started running at Stowe Lake with Ada and Barbara. And God knows, she trained us for 12 weeks on how to run the marathon. That gun went off. We didn't see her again. And when we finished the marathon, we were taken to the medical tent where they said Ada was. She was sitting there being fanned, and she's like, where have you been? I'm hungry, I'm tired, and I'm thirsty. I've been waiting for hours. We're like, Ada, like, we were running a marathon. I'm sorry. She was so upset with us. And she continued until she was 95
Right.
to be an incredibly active person. So I'm very grateful for people I know. I have a friend in his 90s who's been a piano player in New Orleans his entire life and takes lessons every other week. So at 95, he's still learning about the piano. I'm going to ask one more question. Actually, I'm going to ask, there's so many questions here. But I would like people to ask the questions themselves. I think that would be a little bit nicer than just me asking all the questions. And I'm going to ask Jerry Solomon, and I'm going to come back to these other questions if people feel shy about that. Jerry is one of our community ambassadors. He's one of our education volunteers, and he's a retired physician himself. And Jerry, I love your question. Why don't you go ahead and ask Louise? I see you're unmuted.
Yes. Oh, first of all, I want to tell you, I love your book. Just fabulous to read. Your joy of being a physician, a geriatrician, just came out, and it's so enthusiastic to hear a physician with your skill just express a love for what they do. And at the same time, you express your humanity about what happens halfway through the book. You burned out, and I was just so touched and sad to hear what you were going through. So my question to you is, what advice do you have to give to younger and newer physicians who are entering this difficult career as physicians, and particularly now as they're dealing with COVID? How do they, take care of yourself and take care of others? What words of wisdom do you give to them?
Yeah, it's a tough one. I mean, it was hard before COVID. And thank you for the nice words, actually. It's not just me who's enthusiastic. So although there aren't so many geriatricians, when they do studies of who's happy with what they do, we always come out on top. And it may be that if you pick something, that doesn't get much respect and doesn't pay well, it's because you do it for love. And we all love what we do. So, actually people come from other divisions and see us and they're like, you're all so happy. It's like, because what we do is totally awesome. It's also not just organs and diseases, people, so much better. Anyway, so for young people, yes, they're still burning out. A couple of things. I mean, really listening. You saw what happened to me was just the response was unkind. So I think, acknowledging goes a long way, and listening helps a lot. And not blaming them or telling them to do more things. So the medical response has really been, you need to take time for this, and you need to do this, and you need to do that, and and the whole point is that they've got so much they need to be doing that it's completely overwhelming, especially people in that dip of the U-shaped curve, right? They're taking risks. I mean, there were things online with COVID about, actually it was a husband-wife physician team, people I don't know, but on Twitter, and they had a 5-month-old, and they were in New York, and she had to go back to work. So he was saying, she can't touch our baby anymore, because she had the skills that were needed. So he was taking care of the baby, and she had to stand across the room and look at her baby. But she did that because everybody was dying in New York, and she did the right thing. And, to think that, or the ER doc who took her own life because she worked in an underserved setting, and she knew people were dying who didn't need to die. So the stress of what's happened over and above a background where we had so much burnout really requires attention. And we had so much, this is a crisis, so crisis responses. And I think people are talking about, that people will have post-traumatic stress disorder, et cetera, and they're setting up ways of approaching that. My hope, and what many of us are working for, is that we don't make the mistakes we made with the larger burnout epidemic, which was really sort of blaming the victim. This happened, not coincidentally, with the rise of technology, with the lack of human relations, where we're spending so much time on the computer. And part of that is not just if you're in a visit with one of those doctors who spends the whole time on the computer. So already it's a dissatisfying interaction for you as a patient, but it actually turns out it's not so good for the doctor either. But if the doctor doesn't do that, and even if they do, depending on their practice, they're going to have to spend hours at the end of the day, hours that are not paid for or accounted for, finishing up with that computer, because the computer systems were by and large made for billing, not for either patients or clinicians. And then the system adds to that by saying, you need to be more efficient, you need to see more patients. Well, some things can be, at certain health systems, they have 10-minute appointments. Well, 10 minutes might be okay if you're a pretty healthy person with a sprained something, or you've got a little hay fever. But if somebody has a new cancer diagnosis, or if somebody has 5 medical problems, or if somebody's spouse just died, what the hell is 10 minutes? That is an insult to everyone. And that's why doctors are having moral distress, because however they now appear to you, most people, not everyone admittedly, but most people went into medicine because they wanted to take care of human beings. And so what we need to all push back on is the system, the choices, the fiscal choices, the technological choices that are depriving patients of the care they deserve and depriving doctors of the opportunities, the structural setup which enables them to provide that care that the patients deserve.
Thank you so much. Lillian, I'm wondering if you would like to unmute yourself. I love your question so much because, of course, we're a hospice provider, and I was telling Louise earlier, before we got started, I had spoken at a conference on aging, where it seemed that people were just going to continue to age into infinity because there was not anybody except for the panel I was on that was willing to address end-of-life care as part of aging. So, Lillian, why don't you go ahead? I see you're unmuted.
Also, I have to tell you, Susan, I'm 84 years old, and this is my own color hair.
Wow!
Yay! You're my idol.
I
Thank
didn't
you
look
so
like that
much.
at 34. Holy
That's
cow!
awesome. Thank you. You give me hope then.
Which I actually resent, because I don't get the attention I deserve if I had white hair.
I got that. Lillian is also one of our bedside volunteers, which is wonderful.
My question, and I can't find it now, actually has to do with does geriatrics incorporate questions of choice in dying as well as treatment? I think that,
yes.
we do a lot on mission hospice. We have death cafes and that sort of thing. And I will tell you, I belong to 3 or 4 groups of people my age. I mean, I think one of ours just turned 100 the other day. And it's a topic that we come back to very often. And really, there doesn't seem to be any socially acceptable place to put it, if I can say that much. That's all. That's my question.
So I would say that one of the distinguishing features of geriatrics, it's interesting to try and explain this to other doctors because they tend not to get it. Because there are a certain number of conditions we treat just as internists treat them, and most of us started as internists or family docs. But the difference is that we always start with who is this person and what matters to this person. Because as you get older, the risks of every treatment or intervention go up and the benefits go down and the timeline changes. So much of what palliative care does at the point of dying, we do throughout the care of the older person. So we apply it. I mean, if you had to distinguish those two fields, it might be taking the same approach, but for how you live versus how you die. And notably, the people who started palliative care were almost without exception geriatricians. So this approach and paradigm that now, palliative care, it's another one of these ageist things where people generally have an easier time talking about death than about aging. But a lot of the approach to death that has been so satisfying to so many people is in fact how geriatrics has always approached life and death. I had a funny experience, it must be 6 or 7 years ago now, where a patient of mine was in the hospital. He had been gravely ill for some time, and a daughter had been caring for him. Actually a magnificent daughter who apparently had been way overweight and just started running and lost 100 pounds and became this amazing caregiver for her dad. So they used to joke that he saved her life, even as she enabled the last few years of his. It was kind of this gorgeous thing that happened. But anyway, the other sister had come down and I don't know, called an ambulance or something. Anyway, so he's in the hospital. And we decided to have a family meeting because the visiting daughter wanted to do all these things. And the daughter who'd been there for the last 4 years was like, it's not what he wants. And anyway, so the palliative care, so I said, I'm going to go. And there was a young palliative care doc. And he says, well, we can handle this. And then talk. And I said, I know the family, why don't I lead off? And so I opened it and did the meeting. And at the end, he said, wow, you did just what we would have done. I was like, I'm a geriatrician. I was helping people die when you were riding your tricycle, but I didn't actually say that. But it's really the same approach, but applied to your living as well as your dying. What matters to you? Who are you in this world? How do you optimally function so you get to do what matters most to you?
Thank you.
Ellen, would you like to ask your question? Ellen Bloomfield, who is one of our community partners. She works for the County of San Mateo. If you want to unmute yourself, just go ahead, and if you don't.
Okay, I think I'm unmuted. Hi.
Hi.
You talk a lot about people who pretend to not be who they are. You mentioned Nancy Pelosi. I think we all notice it with the president with his orange hair. And I'm wondering what you would say to LGBTQ older adults who are totally invisible and are, they feel they're old and unattractive at 45 and 50.
Right. Well, I think it's tied into the larger society. I mean, this happens to women also. There's a quote in the book, it happens to men later, but I already feel invisible in many cases. And, part of it is you can embrace the invisibility. When my mother was still working, she could do site visits at places others couldn't get into. And she's like, well, nobody notices the little old lady. I just walk on in. Everybody would be like, how did you do that? She said, I just walked in. Nobody said anything. She is, of course, white. That helps too. So in the LGBTQ community, this has been an issue, but I think it's an exaggerated case of the larger situation. Actually, the center in San Francisco, and people have forgotten this, but early on when it opened, they had an elder care program, and they made the people for the elder care program come in the side entrance, not the main entrance, because they were afraid that if the elders walked in the main entrance, all the young LGBTQ people wouldn't go in because it wouldn't be beautiful and cool. So the guys had to go in the other way. It was mostly guys. Anyway, they put a stop to that. But I think it's part and parcel of the same thing of just owning it and owning what is attractive. I mean, I don't know how you all feel, but what looks sexy or attractive to me has changed as I have gotten older. And it's not that I don't appreciate a gorgeous 25-year-old, but I think of it more as I think of a piece of art in a museum, like it's just far away. But what's really going to appeal to me as a human being is going to be an older human being. So I think seeing that and owning it and being honest about it, I always like to talk about sexuality, which is that, yes, it changes, but when you look at why, and people continue to have sex, and the number one reason, there are varied reasons, but the number one reason people don't is lack of partner. It's not lack of interest. So it's especially good to say this to younger people, because, and to talk about it so everybody gets used to it also. So I think, this is the LGBTQ community, it's another intersectionality issue where you're getting a negative synergy of cultural traditions and having people move away from that. Aging is this funny thing where in taking on a prejudice, you are making the world worse for yourself. It's sort of the opposite of our usual self-interest as a species. So I think the more we all stand up in just a calm, it doesn't even have to be strident or angry, because those things put people off. But the best way of doing it is just kind of nonchalant, as if it's an accepted truth in old age, as it is in younger ages, just as if it's nothing, and normalize it. Because the more you normalize things, the more everybody gets used to it.
We'll never forget one of our care meetings about our patients, where the daughter was very concerned. Her father was 91. He was our patient. And the social worker presented the case, and he was interested in this caregiver sexually. And his social worker was a male. And he said to the guy, he said, you got to understand this. I may be old, but I'm not dead yet. And just saying that to I could see all of our biases across the room. And I thought, good for you, but good for you. I have, this may be the last question. I know there's somebody else that has a question that I would like to ask, but I want to be respectful of time too. Would you mind, this person is just asking, could you talk a little bit about suggestions to help change ageism in our everyday activities and in groups that we participate in.
Such a good and important question. I think the more we can do, part of it is what I've been talking about, just owning old age. I think it would be good to be comfortable using the words and just make them more matter of fact. So for instance, in the medical literature and in many publications, you have to use, the only terminology that's allowed is older adult. And the reason is when we ask people what their preferences are among all the words for old age, nobody likes any of them. But I would argue that older adult is itself ageist, because older is relative, and at some point we're just old, just straight up, that's what it is. And when we don't speak things or we lower our voice to say certain words, that empowers them instead of making them just a normal everyday fact of life. And then adult is the group with power. But in using the term older adult, we reinforce that power and devalue elder. So I think language matters. I think intergenerational groups matter. And are there different skill sets? There absolutely are. But what we tend to talk about is the negatives for old age and the positives for youth instead of the other way around, or doing a bit of both. Like, yes, I'm a little bit slower on the computer, but actually I have far better judgment because although you did this quickly, now when you're interviewing for a job, someone's going to be able to find this post. And if it were me, I actually wouldn't hire you. So there are ways in which we have to recognize the strengths of aging and not just the weaknesses. Part of what I talk about in the book, which is true, is as I moved into being older, I kept making excuses for the things I could no longer do. And I wasn't as good about talking about the ways in which I'm happier. I mean, I couldn't have written this book sooner because I didn't have the confidence in myself. And you see this across not just for very privileged people like me, but you see this across age groups and cultures, that there is a comfort with self and with values that comes with age. And does everybody who's older have good judgment or wisdom? No. But if you take an average, it's certainly better. So think about what makes you special. It's probably much of the same thing that always did. And think about what it is you know and are good at now that you weren't as good at before, what you've learned. And sort of emphasize those things and talk about your strengths, not just your weaknesses, and raise the weaknesses of younger people, not just their strengths. Even if it's like you're feeling kind of, this COVID thing has been hard on everyone, but maybe you're feeling bored and like you don't have enough purpose, and you can work on that. But if somebody's stuck at home with a toddler and a teen and they're both going crazy, that could be worse from what I can see. So consider all these different options and doing more things intergenerationally. I feel like one of the biggest problems is that people don't see older people as people. So talk about whatever's in your life and don't let them not talk about it. Another thing that was happening early on as I was giving book talks were older people would come up to me and say, I want to discuss if something had come up about advanced directives. And they would say, I want to discuss this with my adult kids. And they say, no, that's depressing. And what I say to that is to say, like, it's actually kind of depressing to hear about your stressful job all the time too, but that's your reality. I listen to you because I love you, and I need you to listen to me and what my issues are because you love me. We're at different life stages, and different things are important and different things are hard. And we need to talk about the happy things and the hard things both, because that's what we are to each other. We're family.
Yeah. Louise, I want to also respect your time. There's 2 questions that are left. Do you have time to answer those? And one of them has said, don't worry. One person asked, could you talk about vitality and aging versus aging in place, like in a home, or versus aging in place in a community of 65 plus folks? That's a very vital community. And would you imagine any differences there?
I think it really depends on who you are. So some people love to be at home. Well, and some people are wrong about what works, actually, because sometimes we find people moving and thriving and sometimes not. Anyway, so I think it depends on who you are and what you need. Communities are great if you're alone and a little too isolated because it gives you options. And sometimes even, you can be lonely in partnership also. You can be lonely in partnership if you've grown apart. You can be lonely in partnership if one person has a little more cognitive impairment than the other or has some significant hearing loss. So just because you're with someone doesn't mean you don't have the need for more social connections. And having those easily available in a place that's pleasant to live in makes it easier to go down and have some social interaction over dinner or go out for a walk or do any number of activities. So for some people, having those options is terrific. And I know for some people who've been in the sorts of assisted living places that have had a little more flexibility, some have really locked people in rooms, but others have allowed activities in outdoor places as long as people are wearing masks and 6 feet away. That has enabled people in those places to really fare better because they've had daily social contacts. So I think it's important to know who you are and what the quality of life at home is versus what it's like in that community. I think it makes a big difference whether the person decides to move for themselves or is decided for. Having control over your life is a positive at all ages. So, it's important to say to your adult children, I understand. And usually adult children are thinking about safety as their number one goal. And old people think about the quality of their life as their number one goal. And sometimes making explicit that difference in priorities can really help negotiate them. Like, here's a compromise that we can all live with. And then sometimes you may just have to say, let's just remind ourselves that this is more about me than about you. And I'm really glad for your concern. And, that is not what I want. So thinking about who you are is good. The vitality argument can be a problem. It's a bit like the denial of old age problem. Yes, we all want to be vital for as long as possible, but if the community defines itself by vitality, that means when we lose vitality, and all of us as we age will lose more and more vitality unless we suddenly die or are killed. That means we become not a full-fledged community member or a person to be hidden or a person to be sent to a different community. So communities that define themselves based on that vitality, I find eventually do harm to their very own members. There's nothing wrong with enjoying being vital and thriving on it, but you want a community that likes everyone regardless of their function. And old age communities, perhaps because as closer you are to something scary, the more threatened you are by it, will really talk up the vitality. But that is basically creating a really hard life for your future self. So maybe say, I love vitality, but I want a community that can embrace me as I move through all the stages of my old age. And you might also volunteer to be part of that change and think how you make that culture change. You want a purpose when you get up every morning. If we could crack that nut, it would be tremendous. And doing any sort of change from inside is better. So just standing up, and I'm sure there will be other people sharing that concern because we all know it's a matter of time. So how do we make that okay? And how do we support each other through it so you don't feel like you have to hide and be ashamed of actually having been? So this is another thing, like successful aging usually means you're vital. I actually think successful aging means that you live the full arc of a human life. And that means that eventually you have some frailty. And that's okay. And you need help, and that's okay. We all need help at various times throughout life. That is the human condition.
Well, Louise, I wish that you had been available to have this conversation with our family 4 years ago. We had to move my mother against her will. She did not want to move to an assisted living facility at 86. She did not want to live with old people. And
yes, we hear this all the time.
Yes. And so we had to move her out of her state. We had to move her to a place she'd never been. Where my brother lived nearby, who was a nurse, and she told us for 3.5 years how awful it was, every phone call through all 5 of her children. When we arrived there in January to care for her, she got sick and died within 10 days of had a couple of incidents, and within 10 days she died. In those 10 days, we just discovered we had a whole secret life. She was beloved by the caregivers there. She had lots of interactions all day long. Mostly she wouldn't let them in her room, but when she ventured out, they had, you know, puzzle groups, and she had this group and she had that group, and this person from the front desk would have tea with her every day. And those 10 days that I was at her facility, I was just blown away by the incredible life she had in this facility that she did not tell any of her 5 children about, just to make us feel badly about placing her there. And this is our last question today. The question here is, people were healthier overall as they aged because they had lower inflammation levels. If people were consuming more healthy foods, unprocessed foods, eating whole foods, exercising, having reduced stress, less exposure to toxins, so that aging meant a lot less chronic disease from heart disease or strokes or diabetes or autoimmunity, dementia-related disorders, and more vitality while slowly moving towards end of life. What would the field of geriatrics look like? I think we would be living in a completely different world, but that sounds fantastic to me.
Yeah, no, but we know people who do this successfully.
Yes,
it actually
absolutely.
totally works. It's never too late to start it, though the sooner you start it, the better. Actually, in some ways, we start aging in utero. Now, it's pretty hard to control that if you're the person in question, but, all these things make a difference. So we see people who've done this. I actually had a conference call yesterday morning with a guy in Switzerland who's 78, like gorgeous beyond anything. It has done everything right his whole life. A hugely fortunate man, but that's just one example of how well it works. And I have a woman in my practice who's the same, who's like 20 years older than I am and looks fantastic because she does everything right. And I actually don't. I try. I actually do everything right. And then I do a bunch of everything wrong on top of my everything right, which also
balance. It's all about the balance.
Yeah, human. So we can all always try to do better. But we know that makes a difference, and we know people still grow old. So what it tends to do is decrease, not necessarily increase longevity. It increases longevity a bit, but it increases what we call the health span. So the number of years you are healthy, more so than lifespan. And so part of this sort of healthy aging movement is to really help people to do that and to recognize exercise helps you at every age and every state of health or frailty. And that food can make a huge difference in the amount of pain you have at every age also. So I think it might change what we spend much of our day doing, like the balance of how we spend our days, but I don't think it gets rid of the field because there are still age-related conditions and changes in the bodies. And actually the whole field of geroscience is really in the classic American fashion, perhaps working on pills that will do this for you. So I guess you can not do everything right and then take this pill. I think there's probably going to be a lot of them. There are a couple with some early trial results, not yet ready to make a huge difference in any of our lives. So far exercise and good food are still your best bet. But I think it would change some of what we do, but it wouldn't, I think it would just be the next evolution and not an extinction because even the healthiest old people are still old.
Thank you. That question actually was asked by Bri Halpern, who's one of our also community education volunteers and a wonderful health coach. She's helped a lot with dealing with my own inflammation that happened just like clockwork. I turned 60 and I had an autoimmune disease, and I was like, yep. So, Louise, thank you for this beautiful talk today and looking at elderhood from so many different lenses and so many possibilities. And I just am so grateful for the time you've spent with all of us and for us going over. And to all of you who have joined us today, there'll be an email coming out. Louise, if you have any links that you would like me to include in addition to your book and your website, please send those to me. I'm going to try to get this email out this afternoon. There's an evaluation that's very helpful to our community education program. If you're able to complete that and return it as anonymous, it's a Google document that another volunteer put together for me. Thank you all. I'm going to include the resources in terms of the book, The Emperor of Maladies, a resource that was shared online. And if you want to share about your study about aging in place, if you're still looking for folks, and a reminder that you'll have an article, an op-ed piece in the New York Times on Monday. Just thank you so much. It's been really lovely, and I appreciate your flexibility and moving this from April till now because of COVID, and then having to do this online anyway. But it's been a lovely.
Well, it was a pleasure. Thank you all for paying attention, and I guess I can't really shake hands, so bye.
We can wave. We could do some jazz hands, everybody.
Yeah, jazz hands.
I'm going to be able to stay for a couple of minutes after this if people have questions or want to stick around. You're welcome to do so. Thank you all.